Now, the healthcare environment today is very complex and it's changing. There have been dramatic technological advances, such as in genomics, for instance. And the treatments that are available to keep people functioning and living longer have created a situation where we had a rise in chronic diseases. In order to meet the challenges that the patient faces who has a chronic disease, we teach them. And the more informed the patient is, the more likely they are going to have a positive outcome. So your way of teaching the patient is key. Now, teaching every opportunity that you have to interact with the patient where you can teach them something, you need to do it. And as you're performing treatments, you're also teaching the patient. Now, you also had bioethics, right, already? So you know what being informed means, and have maybe informed consent, and informed decisions to provide for healthcare plan. There's also a big emphasis to save money. The healthcare industry is 15 or 16% of the economy, and the rapid escalation in healthcare costs was outpacing the rate of inflation for at least a decade or longer, up until the Great Recession, when things leveled off. And these days, the rate is still going up. It's been slowed down by the Obamacare, before the CARE Act. There's a much bigger emphasis on patients taking control of their own health and making the right decisions. And to do that, they need to be that's key. Now, there are a lot of information sources available, more today than ever before, at the fingertips of everybody. And it's a lot easier to become aware of what the right decisions are. But at the same time, there's a lot of misinformation out there. So you need to be able to differentiate what is a good source of information and what is a questionable source of information. Because you are going to come across patients that have some ideas that you may not agree with or possibly even harmful. So you need to be aware of what's out there and get to know your patients. Another thing is compliance with the healthcare plan, and education, teaching, and health promotion techniques that you can employ will help to keep the patient on track with the plan. Getting the patient involved and active, and actually to agree with their plan of care is essential for that plan of care to guide folks to good outcomes. Studies have shown that when people do take care of themselves and the family and the caregivers around them, the outcomes are usually better in the home environment. Now, another thing that has caused the need for more education is the fact that patients aren't staying in the hospital. The average hospital stay is only a couple of days. It's changed in the last 25, 30 years. We're talking Mary. Mary remembers what it was like before DRG, right?
Oh, yeah.
What was the average patient stay of someone who had appendicitis 20 years ago? 35 days. All right, what about now? Nine, could be same days, right? All right, so that's a dramatic change. Now, I had my appendix out when I was 9. And I was in the hospital like 10 days. And I remember it because when in those days, you were sick, you laid in bed, came over and said I was cute and finished my teeth line, but I didn't get much time out of bed. And actually, in those 10 days, I decompensated from laying flat. And by the time I got out of the hospital and I got home, and I tried to interact with my sibling, I was just, my blood pressure was so low that I was passing out. And it took a couple of days for me to get back to cardiovascular condition. So a lot has changed, in these years. These days, we get people out as quickly as possible, we get them home as quickly as possible. And because of that, a lot of the care now is pushed into the community rather than in centralized hospitals. It also caused the creation of a whole new type of healthcare provided institution called the subacute, which didn't exist to that extent because there was rehab, but not so much subacute. Subacute really was in hospitals. So nowadays, people are very short stays in the hospital, and if they're not well enough to go home yet, they go to subacute for a week or two, and then they're discharged to family care. So the benefit of this is that the outcomes are actually better in the home environment, and the costs are less. So it helps society, and it helps the patient, so it's a win-win for everybody. All right, let's see. Is this question true or false? Health education is an independent function of nursing and a primary nursing responsibility. That's true, right? I said it just as we started, right? So you don't need anyone to tell you that a patient needs education. Everybody needs education. Even you. Family, your children, and your patients, right? Not your clinical instructor. So, when we're talking about education, we're talking about the different primary, secondary, and tertiary prevention education vendors that we need to employ. And in this sense, we're promoting wellness, not just, and preventing disease, not just treating. Now, the whole nursing model of care is different than the medical model of care, the traditional medical model of care. Do you guys remember what that difference is? What's the difference between medical and nursing model?
We're treating the symptoms opposed to the reactions to illness opposed to the illness itself.
Exactly. All right. So the medical model is to treat disease, symptoms. But the nursing model is to treat the body's reaction to disease. Okay? So it's a bit different. You guys remember how to do nursing care plan? You guys remember the nursing process? All right. So what's the first part of the nursing process? Assessment. All right, when does assessment start? And then you get primary information from the patient. And where else do you get primary information? And what about subjective information? Subjective and objective information. So we're going to promote wellness, not just treat disease. And to promote wellness, we need to break the cycle of the etiology of a disease. I want to switch to a different about the roles and responsibilities that you have as nurses and nursing students as well. All right. Now, when it comes to preventing disease, promoting wellness, we look at the beginning of the disease, and we call that the etiology. What are the causative factors? Now, within that are risk factors. And here are your risk factors: environment, social habits, diet, heredity, personality traits, and job. Now, you can affect somebody's risk factors by teaching. Okay? Give me some examples of things you can teach a young, healthy person that they could take with them, which will hopefully prevent chronic disease. Let's talk about number 2, social habits. We all know smoking, alcohol, drugs, fat. There's other things that affect you too. Can we think of one? Okay, unprotected sex is in there as well. That's true. What was that? Seatbelt. Oh, yeah. It's in there. Section here. Headphones can affect hearing. Okay. Loud noise. A lot of young people have that problem after the iPod. It's the decibel level that you can say the iPod. What about diet? What would you teach someone about the diet? So the point is that there are things to do. What about heredity and genetics? Well, you can make a genogram. You do a genogram to help us. So with the patient's input and family's input, you put together a genogram. And from there you look for hereditary and genetic risk. And if you find some, then you can direct your teaching and help promotions towards reducing the risk that posed. Because almost all diseases are multifactorial. So they have several different components which contribute to the disease. So they will have genetic, environmental, and lifestyle components. What about personality traits? Can you predict, is that a risk factor? Some people having a personality? Personalities can do a risk. You guys already have, and what about stress? The point is that you have the risk factors. The risk factors, if you do not alleviate those risk factors, that the etiology of the pathophysiology is and then at some point the body will no longer be able to compensate for the symptoms. So what's your responsibility? Well, in many cases, you are the main go-to between the patient and the healthcare system. You become legally, ethically, and morally responsible for that patient. And are you there? patients and you advocate for the patient when it's possible, so that they can get continuity in the healthcare system and find out not getting the rights that everyone has the right to healthcare. Right? And we begin the nursing process. You guys remember the nursing process? Okay. And the first step is assessment. Now you take together the comprehensive history and the physical assessment, and you put together a nursing diagnosis, right? Now, you're on a Medsurg unit, you have a patient, are you going to do a comprehensive history on that patient? No. But you'll have a chart, you'll have a history, doctor has to write a history for our doctor. So that would be a valuable thing to read when you're assigned a patient. And you're going to see that they may have an acute condition for which they are admitted, but for an exacerbation of a chronic condition, and they may have more than one chronic condition. They may have comorbidity. As a matter of fact, by the age of 65 years old, 4 out of 5 people have at least one chronic condition. So that's a majority of the population. Okay. Now, the chronic conditions, they're there to be treated for the acute condition that they have, but you cannot just dismiss the chronic condition because they all can be contributing factors. And comorbidities for existing chronic conditions make the treatment of the patient a lot more complex because each system interacts, and many times one chronic condition can lead to another chronic condition, such as when diabetes can blindness or kidney disease, right? So, the history of present illness is key at this point. And that's what you want to look for on the Medsurg patients. Because the history of present illness is going to be 99% of your nursing diagnosis. Did they ever tell you in health assessment that history is 99% of the diagnosis? Well, this is the case with it. You don't have a lot of time to read that real these patients. Now, when a patient is admitted to the hospital, at some point, usually right away, somebody is going to write a care plan for that patient. And to write a care plan for a patient, they have to come up with a nursing diagnosis. Now, you ought to be able to, in the electronic medical record, get into the nursing diagnosis area and care plan area. And you'll see that they'll usually have at least 3, right? Is that correct, Mary? They'll have 3 nursing diagnoses, and they'll write a care plan around those. So I want you to, with every patient that you get as a clinical student, to put that together with the homework that you did in the past, when you made your own care plan, and now look for how the hospitals institute the nursing process within their institution and how they document it. So that's very important to help you put together what you learn into the real world of how it applies. Now, nursing diagnoses address the responses, human responses, in the effects of illness. Okay? They are not medical diagnoses. Medical diagnoses become collaborative. You do work with the physician and collaborate with the medical diagnosis as well. Now, nursing diagnosis can be in many, many domains. We have different domains of who a person is. don't just look at the body, you look at the mind, the spirit, the psychosocial aspects of the patient, their culture. So look at the whole person from every facet. And this is also different with the medical mind. So when we make our nursing diagnoses, we're going to address physiological and psychological, spiritual, and cultural issues that that patient has. Okay, now usually when we do nursing diagnosis, it's usually an end diagnosis, and we have a three-part diagnosis. You guys familiar with three-part diagnosis? Do they use three-part at Englewood, you know?
Not sure. I'd have to look into that.
Now, we were talking about education, and education, there usually is always at least one nursing diagnosis. Every patient will know deficit. So, and when you make a nursing care plan for teaching, it's basically done the same exact way. Use the same steps as you do with a nursing diagnosis on a physiological level. All right, now, you have a lot of responsibilities. You are the main person in the patient and in the healthcare delivery system. So you need to know the why. You need to understand the rationales. You need to be good at these care plans. And one of the hardest things to do is to make goals and to measure the outcomes. This is normally we have short-term goals, immediate, and then we have short-term and long-term goals. Obviously, we're going to address the immediate problems right away. Remember Maslow's hierarchy of needs? What is the base of the pyramid? What is the most basic need? It is the physiological needs. So if some of the physiological needs are met, none of the higher needs. So even the most healthy person who has no disease at all could still not be reaching self-actualization or enlightenment. Very few people have ever achieved. But self-actualization, if you haven't achieved it, that would certainly be something that you could you really need to know your patient's health history. You don't have a lot of time with Medsurg patients. You're only going to be there for a few days. You rely on the doctor's written history and physical, but you're also going to be meeting your patients. You're going to be speaking to them, and they have a history to tell you, and you can discern that history. Sometimes it's subtle, sometimes it's alert, and it's constantly changing every day. So you need to be aware of not only their past medical history, their current medical history, and how you're doing acting on it. So you can address that. To do that, you may need to reassess your patients. Some patients need to be one-on-one, constant observation, like they're very acute. You can't do them. Other patients may need 15 minutes, half hour, and so forth. Post-surgical patients have protocols. After someone comes out of surgery, we're going to be assessing them at least 15 minutes. Okay. And less acute patients, they maybe just once a shift. But certainly, at least once. There will never be a patient that you don't have to assess, but a shift if there's something. Now, you're going to make short-term goals for your patient, even for the day that you're there. With something that they need that day. And you can make a short-term goal and see if you can achieve it during that shift. Okay? It may be their breathing pattern, their oxygenation, their pulse, their comfort, pain, skin moisture. They have an immediate problem. That's what I do. And so you design an intervention that's based on evidence and be effective, you implement it, and then you measure whether it was not going to achieve by measuring whether the goal was achieved. So, what is the goal? Let's go. But how do you know if you achieved it? Say your goal was to make your patient happy. Oh, that's a good goal. Simple goal. Make your patient happy. How do you know if they're happy? So funny. All right. So you have to put your goal into words in a way that it can be measured. And measured not indefinitely, but within a specific period of time. Right? All right, so say I wanted to make my patient happy. How would I measure? Happiness. Answering the call. Well, that's more basic need. That's not just happiness. Okay. All right. So, no, but how would you measure happiness? Would you use a tool, a scale, a tool? What's a tool? What kind of tools do we use to measure things in medicine? What scale? Flat scale. Okay. So you have the pain scale, you have the flat scale, you have the gradient scale, Glasgow cone scale. You guys familiar with all those? The Morse-Ball scale. You use Morse-Ball scale in English? Okay. So you go across all those already, right? Now, where did those tools come from? Did someone just imagine them and they're here? Did they want to get it out and people start using it and that was the end of it? No. All right, so a lot of research goes into these tools to validate. Okay. And what's it mean for tools to be validated?
Oh, that is consistent?
It's consistent, so it's reliable, in other words, right? So if you apply the tool in different situations and you're getting the same measurements. So the measurements seem to correlate fairly well in different, without the bias of the environment and so forth. Okay. So the tool is reliable. Now what is validity? So it's measuring what it's supposed to measure, and then if you find a positive, that's a positive real. That's not a false one, right? Or and it's not missing unknown false, a high rate of false negative. All right. So tools are something that a lot of work was put into. It's validated across many different environments, across different groups of patients, and found to be reliable and valid, and have become the standard that by which we, in some cases. And these tools are evolving. There's new ones coming out, shorter ones, more reliable ones, and validated ones. So we keep abreast of that. So back to the question: how are we going to measure if they're happy? How can you make it into something that you can bring forward and say, my intervention worked. Here is why I think it worked. Here's the evidence that it worked.
So
you could look for a happiness scale somewhere. I'm sure there are. There are depression scales, that's depression. But, you know, the best evidence is what? The best evidence is a tool always the best evidence? Patients respond, okay. But direct observation of that response by the nurse, documented. Right? All right, so if you're going to measure happiness, you want to be able to observe something that you can measure. Okay? And observe doesn't always mean you, it could be here. So you may put as your intervention the patient will. The patient will do something. Okay? So, and when we talk about our goal, we usually put it in that format, that the patient will. Okay? So the patient will be happy. Right. So what are signs of happiness? Well, will they verbalize that they feel better? Is that a valid measurement? By the end of the shift, the patient will verbalize that their happiness is now 7 on a scale from 1. Could you measure that? So, and does it have a timeline? All right, so it is a valid goal. And now you make your intervention. And you can measure whether your intervention achieved the outcome that you wanted. Okay? And the outcome that you wanted was that their happiness would be greater than 5. We started out with 4. Okay? All right. Now, the other thing you're doing in the hospital is that you are also collaborating with the other disciplines, medicine, physical therapy, nutrition, respiratory, pharmacy. Now, so we're going to talk about medicine. These are the things you need to know about patients. Number 1, their airway. Okay, so we're going to go right down to the physical needs. When you're there, you need to be aware of your patient's breathing status, their oxygenation status, so you can observe their look. The breathing patterns, the breathing rate, are there any noises in the breathing, just sounds, without the stethoscope, where the stethoscope, are they cyanide, are they using oxygen, and you already know whether they're using oxygen at home. Now, a lot of times patients get oxygen in the hospital. They do not normally receive oxygen. The hospital is a very stressful environment, the stress of hospitalization, physiological form for the patient, physiological stress ulcers, and so pay attention to breathing, pay attention to circulation, airway, breathing, and we pay attention to pain. So you need to know the pain status of all the patients that you're assigned to, and be aware of what interventions are available to you on the medical side, and also aware of what interventions are available to you that are non-pharmacological interventions for pain, and when to apply them. Because you know your vital signs. You know, just their vital signs, and the trends in their vital signs, and a lot of the EMRs that we have now will trend that out for you. You can click and you will see the temperature over time, and you'll see a pattern, and temperature over time, and you'll see a pattern. And of course, you need to know the baseline of the patient as well. You know, if someone is home is constantly 150/78, 150/78. And then you take a reading and it's 164/74, and it's high. I think you gotta go outside about it. Not that far from the baseline. Okay, so someone's baseline is 108/74, and 158/88. So vital signs can be delegated to the nurse's aide. And when you delegate, you're delegating your nursing scope of practice to the nurse's aide. And you are sure that that nurse's aide is capable of performing those vital signs. Yet you still remain responsible for whether those vital signs are done correctly or not. So you're relying on the nurse's aide, but still you are the responsible one. And this is an example of a leadership role. Leadership is another role, a big role that nurses play. So you're going to pay attention to their vital signs, their temperature, that's sort of a pulse. I'm not going to get into high end. It's just a review. I just want to give you an overview of what you need to do when you get to clinical and what you need to be aware of. This is really all the things you do need to be aware of. The patient activity level is very important. And what do I mean by activity level? Like how much you're waving your arms around, how many times you're hitting the remote on the TV. Is that activity level? Well, activity level is something that may be ordered. Usually is ordered, has to be ordered actually. That's why you initial. When a patient is admitted to the hospital, generally a activity order. Okay. So what would be an example of that activity order? All right, so the patient may be on complete bed rest. Who gets complete bed rest? Okay, so someone right after surgery is going to be on bed rest right away. There's still anesthetics that we're wearing off. Vital signs may not be stable. Dolls may not be moving yet. All right, so well, what about somebody who's ED? All right, back block. All right, so what would be another order for activity besides complete bed rest? Adamant chair with assist. Okay. Bed rest with bathroom privileges. Have you heard that one? So you pay attention to their activity level, and you also have to worry about whether they're in a position where they may hurt themselves. So sometimes you need to put 4 rails up instead of 2. In some cases that may be considered fine. But if there's a good reason for the patient's safety, then you should get a doctor over there. And sometimes we have to put mittens on, restraints, wrist restraints. Are there any issues putting on these kind of restraints? Do you need doctor's order for that? Certainly do. And how often do you have to reassess your patient? Right? Now, and then every 8 hours it has to be reordered. Okay? So, activity level also includes activity. Now, you also need to know about our treatment. What treatment is the patient scheduled for that day? And treatments may be simply a blood glucose check. Have you all done that? You all the after-check machine? All right, how's it work at Englewood? Did students have access to the after-check?
No, I have
The
access.
instructor has a code, she will scan your ID in. And then, she knows how to calibrate the machine, it's calibrated. She may like to show you guys how to do that, just did anyone ever calibrate an after-check? Usually when I do it, I allow the students to do it after I scan myself. Of course, I'm there watching. Every hospital is different. Some hospitals don't allow students to do it. All right, but not only that, the dressing changes, very important just now. You're probably going to have quite a few treatments on it. These patients are quite ill, or very ill, lots of comorbidities. You've done dressing changes. You've done pressure ulcers. All right, so what did you see? The report? What did you put on it? What's the first thing you did? All right, so you're going to irrigate. All right. So, bring up something else now. Every patient who comes to the hospital has to have what done? Skin check, right? And look at every part of that person to look for rashes.
Much cough do you have? God damn.
Because if you don't, if someone gets admitted from a long-term care facility,
Much else
if you don't check, they're in the hospital, and 36 hours later, someone finally comes back, suddenly they have a stage 4 disease. You're just going to get charged. And it wouldn't be that far out of the realm of what happens in real life for us to try to pass off pressure ulcers that they experience. Because what happens when you start these diagnoses of abuse is that if someone develops a pressure ulcer on your time, you're going to eat the cost of care. You're not going to get paid for that. Right? So pay very, pay very good attention to the skin integrity of the patient. And there are, more complex treatments, there's wound vacs, and you also get to see a few treatment. Every hospital has different materials that they use, different debriding agents, chemical debriding agents, and different dressings, what their manufacturer and so forth they have some sort of contract with. So I'm not going to talk about pressure ulcers per se. Just know every treatment that is due on the patient. And make sure that you let the professor know so that she can help you and also collaborate with your students, fellow students. You pay attention to the fluid balance of the patient, input and output. So I know, you hear a strict I know, what's a strict I know? What is that? Normally, do you measure the INOs on almost all your patients? Pretty much, right? Every time you enter the Foley, you're going to measure it. But someone who's on strict INOs, you need to very carefully measure everything they did and everything they put. So, how many ways can we get fluid into the body? Well, we can drink fluid. We can eat fluid. This is our food. We take water. So how else do we get fluid? So IV, another major way, is IV fluid. And that could be substantial. Right, so if you're getting 125 milliliters an hour, over 8 hours, that's a liter. Peg tube is the alternate way of eating. Consider that. But anything you into a peg needs to be measured. Also, there are other cases where we consider it as an input. Animates can be considered an input. Using the log volume, for instance. It's possible that you will need to, when the output is subtract the input to get the total volume, for instance, when it comes to, and continuous bladder irrigation is considered an input as well. Anyone know what continuous bladder irrigation is? You've seen patients with continuous bladder irrigation? Anyone not know? Alright, so it's a special Foley with an extra inlet that, where there will be a large, generally large bag, sterile water, sometimes there, that will continuously irrigate the bladder, for people who've had TURPs or bladder surgery. Alright. So, in this case, we need to know how much was infused continuously into the bladder over time versus how much comes out and is measured in the Foley, and we will subtract the input of the irrigation from the Foley output, and the result, the remainder will be considered what? Volume, and the output is what type of fluid? Urine. We all know about that, right? So when you have someone on strychnine, who gets strychnine on? Renal patient? Heart failure patient? Patients can be appropriate and have surgery. Usually for something else after discharge. Big danger of hypovolemia, hypervolemia. Pregnant women. Do they always use strychnine? Alright. Now what about outputs? How many ways do we get this out? Alright, so diarrhea, liquid diarrhea is considered so that counts, right? And this virus, yeah. Urine, obviously. What about bleeding? What about wound exudate? You could have some weeping edemas or weeping cellulitis that you can lose quite a bit of fluid, and that needs to be accounted for. Surgical drain. Right? That's the path. Supposed to be going out for Foley and so forth. But there are other ways that we lose fluid from the body that may not be so easily measured. Can we talk about those? Sweat. Okay. So we lose water through our skin by sweating, and even when we're not sweating, we are losing fluid through our skin by evaporation. So and sweating is dependent on environment. It's possible to lose a liter in an hour. That's right. Put yourself in a hot enough room. You will lose fluid rapidly. But in general, it's about 15%. 15% of our fluid that we take that every day is lost, is sweating, and evaporation. Now, the skin surface tends to hold moisture in. The sebum helps to hold moisture in. The last layer, the granite layer of skin, is generally in place with moisture, but some moisture does still evaporate through the skin as well. Is there another way that we lose moisture? Here, okay, so we have, you know, we can cry a lot, we crying all day, it could become substantial. So that's really not huge now. You know, our body secretions, masturbation. There are, you know, other foods, but this is more major. This is going to account for about 30% of fluid loss. That's it. So you don't want to read it. Okay. So every breath that we take is moist. And you know that, right? Okay. So, and quite a bit of moist. Not only moist, but heat. Heat is lost to the body. Actually, we're dependent on losing heat to our body. You know, dogs don't sweat at all. They're totally dependent on heat. How do they get the fascinating? Well, we can sweat, but we still lose moisture from the heat. And we regulate our body temperature. As a matter of fact, if we're not breathing properly, we may get a fever. You may get a patient that has a slight fever. And all they need to do is use their intense rubber and it will go away. Right? So we're really dependent on having, you know, proper heat regulations. And the loss of fluid through breathing is a lot more than people realize. So in general, the amount of fluid taken in is going to be compared to the amount of fluid measured on the output, which is going to be bigger. Input. All right, so if you see a patient whose I&Os are 1,000 in and 1,200 out, what are you going to worry about? So they're going to be a little. Okay? So I know that your responsibility, and also what about the IV? You need to know, be able to calculate, you know, how much they're getting. You did that in the past, but you make sure you're able to account for that. And another thing you need to do as soon as you see your patient, and, you know, I usually do this right now. I walk in, and I'm checking the IV, introducing myself. I'm looking around the room. I'm looking at how many tubes this person has, what their fluids are. Is there primary IV? Running at the right rate. Is there alarm vision? Is there IV site red? So, you can also look at what type of fluid is north, but that's a little bit, we'll get to that later. And it's also possible when we're giving somebody IV fluids at a fairly high rate, and sometimes we give people a fluid bolus challenge, they can put somebody into fluid overload. So if you don't know your patient, you don't know their renal and cardiovascular status, and you start giving them fluid, you know, it can go long and really fast. So pay attention as well to the signs of fluid overload. You need to be aware of the patient's ECG status. Some of you are going to have telemetry patients. Sometimes there's a telemetry monitor on the floor there. Sometimes the telemetry measures there. There are, but if someone's wearing a telemetry device, you know about it. Anyone have a patient on belly? Right, sometimes change batteries in those things. What's the most frequent alarm you get? Alright, so you're going to pay attention to that. Turn, bathe the patient, make sure those things are okay. Where does this telemetry, well, how does the telemetry work? It's connected radio frequency, and it's displayed. And a telemetry chain nurses look at the tracing and determine when it's changed in the patient. And when it's a serious change, You need to know your patient's lab, no? Your patient's lab. So generally, you guys are going to be in the morning. You're going to get there at 7-ish or so. They probably have already done the labs. They generally go on the labs, very early. Some places start at 4, which is around 6. Go lab. And if it's a critical lab, you get results real fast. If it's critical, actually call the floor and notify you that it's a critical lab. Generally, you'll get the results between 9 and 11 in the morning. And sometimes you have to wait for your medicine, your medications, because they may be dependent on a lab result, potassium level, so you need to be aware of your patient's lab. If I get assigned a patient, I look at their labs. You can also get a trending report of labs as well as what you can lab assign. And look at those. And if you notice that somebody might be anemic, very common. Disease. How do you know? What is normal hemoglobin? 12. Alright, so a little difference between men and women, right? Men are higher than women. So when do you expect, what is mild versus moderate versus severe anemia? Less than 6? Yes. Very good. I have patients less than 7. It depends. If it's accumulated gradually, they may not have overt symptoms when they're at rest, even at such a low level. If it came on quite rapidly. If you're normally 12 and the next or suddenly you're 6, you're going to be a mess. But if you gradually begin from 12 and over 5 years, you may not have it. But when you don't have it, you reverse. But I don't want to emphasize that too much because 6 is a pretty critical level when it comes to 10 is the dividing line between mild and moderate. And you usually don't give transfusions until the hemoglobin. And that's also a criteria for giving a medication which mimics or actually is hematopoietin or erythropoietin. You guys know what that medication is? You guys know what erythropoietin is? Where does it come from? Erythropoietin comes from the bone marrow. What organ secretes erythropoietin? Kidney. Okay, so kidney. So, any of you have chronic kidney disease? A lot of your patients are going to have that. And it's directly related to the fact that kidney's damaged and the level of erythropoietin is just not there. So they'll respond really well to average injections. Anyway, let's not get off too far from that. So basically, your lab values, you need to be aware of them. You need to see what the last one was, and see what was ordered and see what pending. But it's important to respect that day. What you need to know, I'm going to look from Mark. Your normal patient repair. I need to look my meds up. Hopefully the professor or instructor will rinse them on for you, give it to you, you can go, let your meds so that you're ready. When you're ready to give meds, you're going to get quiz, because that's what I did. I never let someone do a med without them telling me what for, why, when, possible, not really. Okay. Right? So you have to be able to do that. And eventually, medications are a big subject. A lot of people ask me how to get to know them, and really it's just Giving him that is a great way to remember. So try to give him that. Try to get equal chance to go over it. Give him that chance. If you're missing, if you haven't given IV meds, or I am, or you have done flushes, or so forth, just like your clinical instructor might, so you can get that experience. Now, medications also are given sub-Q, IM, galactic roller. I just want to remind you what they need to know the difference between a sub-Q and an IM, right? IM injections are fairly rare these days in the hospital floor. They still happen, and when they happen, I get excited because there's a chance. There's not that many more, but B12, still good. So, well, taking your pencil injection. What else is that?
Hydroxyzine, Vistaril for nausea.
Right, yeah. So this will tie in.
This is all we're doing today. This is all we're doing.
We'll see what this one.
She keeps doing it all the time.
No.
So,
No chance, man.
yeah, you need to choose the right syringe,
Tuesdays are gonna suck. Tuesdays are gonna suck.
the right angle.
Oh, God. Gotta get through it. Man,
Choose the right method. Lead back on track.
I need to start going to sleep early on Mondays. Gotta start going to sleep early on Mondays.
Use the aspirate, but these days,
Ah, man.
really don't. So, there was a good rationale for aspirating. It's just really hard to aspirate. So let's talk about, you also need to know blood products on your patient, what, so these are your IV meds. And so you have to do a primary IV, a secondary IV, IV feedback. And you need to know that saving lock gets flushed once a shift. Saving lock, here's how many hours. Back the site, like I said before, for any signs of infiltration or excavation. So, and drip rates, how to use the pump. If you're not real comfortable with that, talk to your clinical instructor. Every hospital has different type pumps, but the fundamental process is the same. Some of the more sophisticated pumps you can look up a library of medications, call that medication pump, and it will already know what the recommended rates are and dosages are for that drug. If one of your patients is due for a blood transfusion, you need to know whether they've had a cut and cross performed. And then you have at least 20 days that week. And that, then the red blood cell will tear. You need to know if they've had a history of any blood transfusions. Okay. And specifics of giving, anyone here giving blood? You haven't had a chance to observe did observe, I need 2 nurses, right? And do 3 checks, prepare, punctuation, right. Order, bag, type, right? Baseline last time. Temperature reported, you have a need, you have delayed reaction, so that shouldn't be that. Nutrition, we're gonna have nutritional diet orders, just like activity orders. So what are some diets that you have to do? Mechanical saw, okay. Puree, another one, right? Another one. Bland, puree. What about 2 grams sodium? NAS, no added salt. Any others? Big one. Cognac diet? Diet? What about that? Well, low sodium is a big. All right, so 1,800 calorie ADA diet. Remember that one? Directed diabetes associated with diabetes? All right, but some people didn't help with eating. Right? Once in a while, feeders. Beware of the swallowing ability of your patient. Do they have dysphagia? Do they have high risk of dysphagia? So, the last thing you want is for the person to have.
Holy cannoli, man.
Now, we give nutrition also through PEGs. Have you done PEGs? Medications with PEG? Good enough? So sometimes we do PEG feedings, nutritional supplements, and we have, Lucerna, and we have the renal diet, hormonal care. Diet for people with liver disease. And the components of those foods are all based on what the patient can tolerate. So somebody who has liver disease or you had GI? You had GI and sensory organs of digestion? Medsurg II. You have it. Good. All right, so when someone has hepatic failure, what type of diet are they going to have? What's going to be restricted? Protein, who said it? Yeah. All right. Any real diet? Don't too worry about left to right. All right. So, when you're going to do a boneless feeding, in some cases we're going to have to do some feeding on top. Okay, because program and the root pumps or what else is going to have. You guys have to set it up, filling the tubing, the back tubing, and letting it through the pump. So that has to be changed every 24 hours, right? No. So if someone has a PEG tube and you have an order to start or give a bolus, right? 1 can. So you're approaching the patient, you see the peg. What do you need to do? You said raise the head of the bed? Very good. All right. So when someone's eating, you sit up. You don't eat like that, right? Well, just because instead of putting the food into your mouth or putting it directly into your stomach, doesn't mean you still don't. You still need to sit up. You don't. A lot of people try to do that. They leave the patient down. At least 30 degrees. Because they can still aspirate. Okay. All right, but also, what else we're going to do to make sure that the peg tube is in place and working? You're going to check residual, right? All right. Now, what about putting a little bit of air and listening to what further? Done that? All right, so would it make sense to put a little air in first and then check for residual? And how much do you get? Say you got 50. What's the dividing line? Well, most places it's 100. You know the dividing line? And what is it, 100?
Is 100, yeah.
So if the residual is 100 or less, you're okay. 100 and I don't know if it's less than 100, I forget that. But yeah, if it's less than 100, you're okay. If it's more than 100, you're in the hole. Okay. All right, so you're also listening for placement. But really the best way to know if the patient is in place is what? Right, and you can't use one until they've done that. Okay, and there's an order that can be used. Sometimes you have a patient who just had a peg tube done, maybe that's why they're there. All right, so nutrition is big. You need to know radiography. Hopefully you'll get OTPM. Has to be done for the central line. So I can go right into the subphase and spill into the heart and mix with the log volume as well. That's the only safe way to do it. You may add insulin to it. Here they're saying you may add Reglan for someone whose GI tract is slowed down from neuropathy. All right, so hopefully some of your patients are going to go down for testing and you're going to be able to go with them. Whenever, if someone was assigned a patient and they had a test that day, you know, for a CAT scan, a endoscopy or something, I would allow the students to go as long as it's okay with the hospital. Usually it is, they like to have students around. So, you know, hopefully you get to see that. MRI has its own precautions. You must remember those are metal objects, for instance, right? In the body and on the body. CAT scan, you know, without radiation exposure. And you need to know whether your patient is allergic to radiographic dyes as well. Because that can happen, especially there's a lot of cross allergies between people who have an iodine allergy and they're linked to the radiographic dyes. So you want to be aware of that. Make sure that everyone involved is aware. And just because it's not documented in the chart, the patient may say to you, you know, oh, well, I'm going out for a CAT scan, well, I had a reaction last time. And it may not be documented, so you know, you guys in the experts like. Of course, all diagnostic procedures need consent, as well as blood products need consent. It's your responsibility as a nurse to make sure that all your procedures are in order before you can allow transportation. Check. That's back assessment. So. All right, so any kind of pre-surgical procedure or invasive procedure that may be done at the bedside, like thoracentesis, These all need consent as well, and you're going to go through the pre-op checklist. If you've done a pre-op checklist, you know all about pre-op checklist, right? What is the pre-op checklist? You laugh, right? What if you have a patient who is on Coumadin and they come to the hospital and they're scheduled for surgery, and you ask them, when was the last time you took your Coumadin? And they said, I took it last night. What would be your concern? Wait. All right, so what would be the proper way for someone who's scheduled for surgery to handle their anticoagulant? Of course, we'll stop. Usually they're given orders to stop. Or they also have to stop aspirin, the antiplatelet meds, will get the job. Agonite. Those are all antiplatelet meds as well. So it's not just aspirin, Latix. And Coumadin, now if they need to be anticoagulated because they have AFib, serious risk. If they're not anticoagulated, then we're going to transfer them off Coumadin, which has a very long half-life in terms of days. So it takes a few days to get out of the system, and we'll transfer them to a anticoagulant which is short-acting and reversible like heparin. So a lot of your patients in the hospital they'll have an extra day. Here's a case where we approve an extra day, there's a comorbidity, we're tapering them off Coumadin, and they want to do a proper dose of heparin. And the good thing about heparin is it has an antidote. What's the antidote for heparin? Chlorine sulfate. So if we're doing our last lab schedule surgery, which is 6 a.m. They take the PTINR at that evening or right before, and the PTT, if they, we would have stopped the heparin ahead of time, but our goal is to keep the window where they are not anticoagulated as short as possible. So we want them to be not anticoagulated right before surgery, through surgery, and then right after surgery we'll start anticoagulating. So heparin is reversible and a short half-life. So we switch on the heparin, stop it, double stop it. Most surgery patients, now when people get out of surgery, they're going to go to the pack, they're going to be cold. They have respiratory, so you have pain issues. Cold is a big deal with them. Hopefully they're stable. If they're enough, it's a big deal. Right? And like the whole day, after 6 hours. But you're going to get them, they're maybe still groggy, still under anesthetic. They're going to have absent bowel sound. They might still be cold. They might be nauseous. They may be bleeding. They may have lost blood. But have anyone here had someone right after surgery? You did. What happened?
Not in the Medsurg.
What was it?
I work in recovery.
Are you working?
Yeah.
What are you?
Okay.
That's a good experience. All right. All right, so when someone comes to the floor, you need new orders of fluid, right? You're going to need all the orders after surgery. go back to what they have for surgery, so. If you don't have it, you're gonna have to get it. Get on the phone. Get to work. So we didn't take it out, but it's crucial. They're gonna have strip diagnose. Labs. A lot of them will just come out intubation as well. They certainly require intubation. The breathing muscles are tight. Irritation.
We have 10 minutes.
They may have pain and dryness in the throat.
Yeah.
Sometimes the throat can swell up after extubation. Careful for that. Pay attention when there's drier. If the swelling is getting bad. So oxygenation, fluid balance, electrolyte levels, respiratory status, these are all key.
It's $5.
And pain, of course.
I used to have it.
Any kind of drains that they may have. You're not going to do the first dressing change if you see unusual constantly reassess your patients depending on their acuity. You'll get a sense of that also through protocol. You're at the center, everyone else is the periphery. Everyone's depending on you. You're the first go-between the patient and the rest of the healthcare system. So, speech, physical therapy, respiratory therapy. All right, so most of the patients are going to be old. It's just the way it is. You won't have young patients. There are young patients in the hospital. You may die. It's interesting when we get to older patients. Stages of life and the struggles that people go through, ridiculous struggles, and what happens when someone it's good to see. But as people age, they will have some age-related issues. Now, their ability to sense dehydration is lessened, so they tend not to drink enough. And sometimes they do that on purpose, so they don't have to urinate because they feel they're urinating too much. Prostate or bladder issues, prolapse issues. But, so we can help to ensure that they get the right amount of hydration. In general, elderly people are more used to pain and can tolerate a high level of pain. That was the old thinking. It's still true, but there is also a new thinking that says that their pain is blunted because of neuropathy. Many conditions can contribute to neuropathy, especially in diabetes. So, pain, neuropathic pain is one of the hardest pains to treat. Look for the comorbidities. Their skin's going to be very dry, it's going to be very thin, and easily bruised, easily damaged from shear forces, even just turning pulling sheets too rapidly from one patient because skin tear. So you got to be really, really careful, especially with the frail elderly. And, senses, hearing, sight, of course, you may need to compensate. As well as their learning ability, it may be a little bit slower, depending on that. And if they have dementia, dementia is 50% of people have Alzheimer's, they lack underlying. So that's pretty bad. Yeah, that's just Alzheimer's. Now, hopefully, in the midst of all that you did, you went through these probably some of the major things you have to consider with your patients, but hopefully at the end of the day, you'll be able to evaluate whether those little interventions that you can work. And that's an important part of that, because that's something your clinical instructor likes to see. You know, you made a little care plan, you made a little intervention, you evaluate, and it worked or not. But, you know, we're not looking for you to rewrite the Medsurg book, but at least, you know, once a week, take one patient and try to do it like that. And then we get to discharge. Now, discharge is really where, you know, not only do we educate the patient at every step along the way, if they're receptive, it doesn't make sense to try to educate a patient who's been sedated or is so anxious. Someone has to be ready physically, emotionally, and experientially ready. But we have a responsibility to do discharge teaching, especially nowadays when we're putting so many people out so quickly back to the community and back to the family as caregivers. So we teach not just the patient, we teach the family. And discharge teaching is an essential part, it's mandatory. You do have some advantages because you have online printable materials you can hand to the patient if they're able to read. And you can, you know, collaborate with other disciplines in teaching there as well. But nurses really are the community caregivers. They coordinate care in the community more so than part of the healthcare system. Someone getting home care, the nurse is coordinating, even coordinating the physical therapy part that they work on with the nurse. Many patients at home do get physical therapy at discharge. So the teaching part is very, very important. Any questions? What time? Oh, no. I wanted to do that rather than the boring capital thing. Yeah.
I know the department is like, how are they like, what do we go off of, like, how many questions?
Well, syllabus, there's 4 exams. Each exam is going to be a minimum of 75 questions. And as these semesters go on, the exams get a little longer. So by the end, the final will be about 100. Maybe, you know, I think my final last semester was 120 questions. But having more questions is better for you. Okay?
So with the answers.
Different levels of questions